All right, let's talk about one of the biggest topics for your AFK exam, cardiovascular considerations. We're going to cut through the noise and focus on the high-yield, must-know info you'll need to manage these patients safely and, of course, ace your exam. Let's get right into it. So, here's the plan. We'll kick things off with blood pressure basics, then jump into handling hypertensive patients. After that, we'll tackle the heavy hitters, ischemic heart disease, and cover the essentials of prophylaxis. We'll wrap it all up with a quick-fire review of the key numbers you absolutely have to know. Pretty straightforward, right? Okay, first things first, we have to set the stage. Let's talk about the fundamentals of blood pressure management. So, on one side of the spectrum, you've got hypotension. The big thing to remember here, it can cause your patient to faint, syncope, because not enough blood is getting to their brain. So, if your patient starts feeling lightheaded or their heart is racing, especially after they've been in the chair for a while, this should be on your radar. Now, on the other end, we have hypertension. This table right here, this is your bread and butter. It lays out the stages from normal all the way up to stage 2. You absolutely have to know these numbers cold. They're going to guide every decision you make, and you can bet they'll show up on the AFK. Okay, so you know the stages. Great. But what does that actually mean for you, in the clinic, with a patient in the chair? Let's get practical. You've probably heard the debate about using epinephrine in cardiac patients, right? Well, this quote gets right to the heart of it. The research is clear. Even one single carpal of Lido with epi can basically double the epinephrine in a patient's system. This isn't just a random rule. It's backed by solid evidence, and it's why we have to be so careful. And that leads us to a number you need to burn into your brain, 0.04 milligrams. That's it. That's the max cardiac dose of epinephrine. What does that look like in real life? It's about 2 carpules of your standard 1 to 100,000 epi. 2. That's your limit. Okay, here's another hard stop, a non-negotiable. If your patient walks in and their blood pressure is 180 over 110 or higher, you stop. No elective treatment, period. You send them for a medical consult. This is a huge patient safety issue. So what happens when the numbers are sky high, like over 180 over 120? This is a hypertensive crisis, but there's a crucial difference between an urgency and an emergency. The blood pressure number is the same, but the real question is there target organ damage? Are they having a heart attack or a stroke? If yes, that's an emergency. Call 911. If no, it's an urgency. You still need to get them to a doctor right away, but you don't need to call an ambulance. All right, let's level up. We're moving into the really acute stuff, ischemic heart disease. We're talking angina versus a full-blown heart attack. Getting this right and getting it right fast can literally save a life. So your patient has a known history of angina and they start getting chest pain. What do? First, sit them upright. Then get that nitroglycerin under their tongue. Now here are the magic numbers. You can give a dose every 5 minutes, up to a maximum of 3 doses in 15 minutes. 3 doses, 15 minutes. Got it? But what if you've given 3 doses of nitro, 15 minutes have passed, and the pain is still there? This is the moment everything changes. Your diagnosis has to shift. So what are we thinking now? It's a myocardial infarction, a heart attack. The angina protocol is over. We're now in a full-blown medical emergency, and our response has to reflect that. So for a suspected MI, what's your game plan? First 2 steps, no hesitation, call 911 and get them on oxygen. Then you can think about the classic MONA acronym. Now M is for morphine, which EMS will handle, but you can give oxygen, nitroglycerin, and aspirin. Just remember to check for contraindications. Don't give nitro if their blood pressure is low, and obviously no aspirin if they have an allergy. Okay, we've covered the acute emergencies. Now let's switch gears a bit and talk about managing patients with some common chronic conditions. This is the day-to-day stuff you'll see all the time. Pay close attention here, because this is a big one. Infective endocarditis prophylaxis. The guidelines have changed over the years, and now it's only for a very specific, very small group of high-risk patients. You need to know these 4 categories by heart. Don't go prescribing antibiotics for anyone else, just these 4. And if your patient does fall into one of those categories, this table is your exam day gold. The go-to standard, 2 grams of amoxicillin. Easy. But you also have to know what to do if they're allergic to penicillin or can't take pills, so know your alternatives and know those doses. All right, another major topic that's closely tied to cardiovascular health is a stroke, or CVA.
Let's talk about how to recognize it and what to do.
For any patient who's had a stroke, there's one really important rule you need to remember: the 6-month rule. That means no elective dental care for 6 months post-stroke. It's just too risky. If it's a true emergency, you need to consult with their physician first.
So how do you spot a stroke in your chair? It's all about 2 words: sudden and unilateral. Sudden, severe headache. Sudden, vision change. Unilateral, meaning one-sided, facial droop, or weakness. If you see these signs, it's a code red. Call 911 immediately and start oxygen.
Okay, wow, that was a lot of information. Let's boil it all down. We're going to do a super fast, high-yield review of the key numbers and facts you absolutely positively have to know for the exam. Ready? First up, 180/110. That's your do not treat blood pressure. Next, 0.04 milligrams of epinephrine, the cardiac dose. Remember, that's 2 carpules.
6 months, the waiting period after a stroke for any elective work.
And 2 grams of amoxicillin, your standard IE prophylaxis dose. All right, one last scenario to put it all together. Your patient has a history of hypertension. They suddenly develop a unilateral facial droop. You've done the right thing and called 911. So what is the very next thing you do? Think about it. Getting this priority straight is exactly the kind of clinical judgment the AFK is designed to test. What's your move?